discussion. For the audience, I think feel free to raise your hand or head to the mic. Do we have a mic here? Yes, we have 2 mics here. Okay. Please state your name and where do you come from and your question, please. Yeah.
Hi, my name is Alex. I'm a clinical hypnotherapist. So my question will be to Dr. Arnil. Because I see the approach is still very treatment-based, how about the preventative measure? Another thing is I see that for the allied health, I don't see a psychologist there. Yeah, so I'm from psychology background, that's why I asked. So what's the role for a health psychologist in the team? Because the role for health psychologists is basically they focus on the psychosocial part of the treatment and also bring public awareness, public education about the disease. Because the reason why I ask this question is because I myself, I have the experience of taking care of my grandfather who had stage 3 colorectal cancer, and he was like in his 70s, and he was getting diagnosed, and it's a big struggle for him to come to terms that he had this disease and he don't know how to face it. So I think the psychosocial part is very, very important as well. Thank you.
All right. Whew, very tough question. Would you like to take this? Okay, I think it's very clear. I know that I showed that table of between MDTs and all that. It's not a complete table. All right. I apologize for leaving out a psychologist there. Any psychologist? Are you a psychologist? No. Are you a psychologist?
Working towards that.
Working towards any other psychologists? Okay, minta maaf. Okay, so I think that when it comes to, over the years as I went to training and all that, I think there's a lot of efficiency when it comes to cancer care. Now, the diagnosis of cancer is so important that the emotion just gets over you, right? So a surgeon would say diagnose the cancer, then you see the oncologist, and then sometimes the patient don't even know the diagnosis. You speak to this doctor, the oncologist will have to, and everyone breaks down with that. So you're quite rightly, to point out that we need psychologists, even what we call a psychiatrist who's involved in counseling. It should be there. But in my early years of practice, it probably wasn't. Honestly speaking, everyone has got to manage it on themselves. The family doesn't know what's going on, and you need counseling not just for the family. Not for the patient, but also for the surrounding family.
One thing I need to add on. We don't need a psychiatrist here.
No, we don't need.
But because psychiatry is for severe mental health.
Well, it's a term that has been used, but of course I don't tell the patient people to see a psychiatrist. It's probably a psychiatrist that has some, how do I say, understanding on giving counseling and all that. We don't mention that. All right? But it's someone that it's around there. But I hope that things are getting better over time. It's just a matter of having enough personnel who are trained prior to that. I think a lot of private centers may have that facility better. I know University Blair has got a counselor on the side waiting to talk to the patients, and also as oncologists, I myself need to be aware that, okay, not just because you're sad, I need to refer you. No, I think you need to just talk to somebody about it. So it's very important to look at that. Did I answer the question, or is there more?
Okay, we have other panels to add on. Okay, yeah,
sure. We see this problem continuously because the patient is diagnosed, surgical side, and referred to the oncologist. And breaking the news, we have to spend sometimes half an hour explaining to the patient, to the family members, And this is very important because this is where you build a rapport with the patient. The patient has to trust you and trust that you are giving you the correct information. So for the doctor, the biggest challenge is explaining the diagnosis. He has to tell the truth. There are some family members who come and tell you, hey, don't tell him you got cancer. No. That's even worse. How to tell the patient you don't have cancer when the patient has got cancer and you have to treat cancer, treatment is that. So how to, it's a very careful this thing you have to do. Because one, patient are in denial. Secondly, you have to break the news carefully. You have to also explain the positive sides of having treatment. And now with modern treatment, with these things, many people can be cured. So you see, the first patient thought in his mind is cancer means death. So that's not really true. Many other patients, stage 1, stage 2 cancer can be cured. So if you tell them, yes, you can be cured, but you need certain treatment, and why we are giving you this treatment, get an informed consent for treatment, that means they agree for treatment, and then explain and stick to you. And we find many other patients who build up the rapport with the doctor, they'll stick to you. They'll still come back and see you. They want to see you because you are like they are holding hands. They need somebody to hold hands. And the doctor is one. And we have also what we call as nurse specialists who are very close to these colorectal patients or breast cancer patients. They are like the middle person. So they build up a lot of rapport with that nurse. Any problem, they contact the nurse. And the nurse will contact us. So they know where to contact. So this is very important. Building that rapport is so important. The trust. And they know that you can get you through the journey. And then, yes, then the patient will say, yes, I will fight and I will get through this. So the young people and old people, young people are more difficult. Old people, yes, they are very worried, I don't want chemo, because first thing in your mind, chemo means finish, you're gone. That's very bad news. But slowly you have to explain and then they will take it treatment. And you have to guide them through the treatment. Be there to support them through the treatment. That's so important. And that they trust you. So that building up of the rapport, the trust, not only with the patient, but with the family members is so important, very important.
Maybe I just add on one thing. Actually, the best care or best psychological input is not from the doctors or even from the psychologists. The best psychological input is from another patient and another caretaker who has gone through what the patient is going to experience. That sharing that you are not alone, that there are many other people like you, and what is the journey going to be like? Because many of the patients, once diagnosed, they're not sure what it is all about because they have never had experience with cancer before, and they do not, there's a lot of fear in them. So when they have somebody that they can talk to who has gone through the same thing, that actually improve and actually dampen down a lot of the psychological trauma that they have.
I think I can't agree more with what's shared by our panels. In our real life, what we see MDT is very important, but sometimes are we going to refer to psychologists at the first time meeting our patients? There's already two questions. You know why? Because the patient may not just accept it. Why do I'm coming here to see you for a cancer treatment, but why you are referring me to see a psychologist? Are they going to treat my cancer? I think rapport is one thing. Referring to the right person, someone who has experienced the same thing. Since our track here is actually mainly on allied health professionals, we have a lot of allied health professionals today, but we are mainly having some medical oncologists, clinical oncologists. I actually have a question towards Dr. Teh as well. Actually, how can the allied health professionals better support our young cancer survivor returning to school or social life? Because we are fully aware of the pediatrics cancer management is actually time consuming. Okay, you have any things that can share with us?
Okay, a very good question. Unfortunately, many of the patients who require treatment for cancer in childhood, they have to stop or interrupt their life, and that includes school, unfortunately. So, because otherwise they're at very high risk of getting febrile neutropenias, treatment interruptions and stuff like that. So, but fortunately, there's got many of these children, if they are school going, they still have got good social support through virtual consultations with their teachers. Many of the school teachers still connect and provide some amount of homework to them. We have got Some hospitals have got school in the hospital kind of program where we have got teachers from the Ministry of Education who are actually stationed in the hospital. So when the children are in the hospital, they get seen by these teachers. We do face problems after completion of treatment. Some children, the family is so afraid that to send them back to school. This is sometimes a challenge, especially if they have got problems with ambulation and stability in the child with brain tumors. In some of these patients, unfortunately, we have to get our school and hospital teachers to help assist them to transition the period as they get ready to go back to school. They still come back to the hospital in the meantime to see the teachers and get some form of education because they feel a bit safer coming to the hospital rather than going to the school. But we hope that this is just a transition as they then subsequently go out into the community.
Thanks for sharing. We will invite more questions. Yes.
My name is Dr. Malik. I'm from the Cancer Society of Maldives, also MD Psychiatry UM. But then my question is just a follow-up from yours. After we have a lot of hematological childhood cancers in Maldives because we have a lot of hemoglobinopathies as well, us being an island nation, and a lot of cure rates now. And we have a back-to-school program that the society NCCM runs. But the problem is sometimes, even if the child is well enough to participate in sports and all that, there's a lot of hesitancy. How do we address this lifestyle progress throughout, for future, when they are aging, when they're getting older?
I think there are a few challenges. First is the patient himself or herself. Many of the patients actually want to be active. They are only limited by the surrounding, and the surrounding could be from the family members. So first is to convince the family to let the child go. The child need to play and have fun, and the physical activity will improve the well-being of the child. With time, of course, the family eventually will accept that. The second is the school environment. Many of the teachers are so frightened that the children are so fragile, and if they participate in the activities, they will fall, injure themselves, or have other problems. In this, then we need to write to the school saying that this child is already cured of the cancer, he's no longer in that fragile state anymore, and he's fit to join any of the physical activities in school. So there's a lot of communication that needs to happen as and when it arises. Yeah.
Thank you, Dr. Teh. Any other questions? Jefferson? You're the MC. And you have a question. Welcome.
Right, thank you so much, Dr. Teh, and also Dr. Arnil, for highlighting the importance and also the challenges of MDT, right? Just to complement of what a psychologist would actually complement to cancer care itself, right? So how do we integrate a child back into school or to help them in terms of social? So what we did in NCCM is actually we did cancer support groups for the children, and it's a very non-invasive form of support. So just now we also mentioned that if we refer a patient to a psychologist, you'll get very denied, you'll get very fearful. So what we realized that, hey, let's just do a form of support group. Then they felt more comfortable, and we don't address ourselves as psychologists. Right? Our play therapists in the hospital, they address themselves as teachers, cikgu, they always call them cikgu. Right? So with that, they felt more comfortable, more relatable to them, and then later on we only do some screening further to determine is it a clinical case, does it require further psychotherapy. With that, we found that it's more easier for them to access these services rather than very invasive direct referral to them. So hopefully that can help to complement to some concerns.
Okay, thank you, Jefferson, for sharing. I think let's keep the ball rolling. Any other questions from the floor? Yeah, please. Your name and where do you come from?
Hi, my name. Hi, my name is Puishi. I'm a fourth-year medical student from IMU. So I have a question to Dr. Teh. So do you?
Seems like pediatrics oncology is the popular topic today. Yeah. Okay.
do you think Malaysia's local training program is adequate and sufficient to meet the need of pediatric oncologists or perhaps pediatric surgeon as well currently?
We have only 36 in Malaysia, right? Just now I looked into the data shared by Dr. Teh. Only 36 pediatric oncologists.
I would say yes, I'm locally trained. I graduated from University Malaya. And I didn't do masters, but I did MRC PCH. And many of the training happens in Malaysia. I feel that if you are not locally trained, then there's a lot of things which is very different. Epidemiology and all that is very different between Malaysia as well as the foreign countries. So for example, we do see a lot more patients with intracranial germ cell tumors in this part of the world compared to in Europe and also in America. So the local training is sufficient. Of course, we do complement some of the local training with overseas training as well. It's not just all local.
She wants to join the pediatric. Are you planning to join the pediatric? Oh, okay. Maybe one more question from the floor. Because we have another 5 minutes left. Yeah,
so my question, my name is Afham from the Department Hospital USM from here. So my question is to Dr. Teh. Under the topic of distributive justice and treatment coverage, what is your view on the centralization of treatment? For example, certain chemotherapy, for example, observed by my friend, only available in HKL, or some operation, for example, which treatment is recommended to be performed by operation by the surgeon with experience. So what's your view on the centralization of treatment?
Yes, there's definitely a need for centralization, but there's also a need for decentralization, and it needs to be balanced between centralization and decentralization. There are certain countries that have moved totally centralized. So, for example, in Netherlands, they had like maybe about 20 different pediatric oncology centers in the past, but they have now become only a single center, and that's in Princess Maximus Cancer Center in Netherlands. So they have moved towards that because the first and most important part is about accessibility. So if you want to centralize something, it needs to be accessible. And accessible means that you must have got good connectivity, both in terms of transport and in terms of your social support services. So if you've got centralization of services, for example, train, bus, road, flights should be able to get to you easily without problems. And this includes patients with emergency services, in emergency setting. In other words, they present in a very late stage manner, and they may not be too safe to be transferred out. So that needs to be taken into account. And then of course the treatment center, which is centralized, need to have got good supportive services. Like for example, I work in hospital called Tunku Aziza. We've got good supportive care from National Cancer Society of Malaysia that provides House of Hope to our patients and family, whereby although they are from far away, they do have accommodation where they get which is provided to them for free. So all those things need to be taken into account before we centralize everything. But there are certain treatment which is very, very rarely needed, and we need to have specialization as in improvement in care, and that we have no choice but to centralize services. Otherwise, we will just dilute everything away, and we won't be able to know how we perform and how we can improve on the care that we are delivering to the patients.
Good sharing. So I think we should have another separate sections on the pediatric oncology today. But in order not to let our panels to left free there, the last question to all actually, where do you see allied health evolving in survivorship over the next 5 years? Maybe we can ask Dato Sri. Where do you see all our allied health evolving in the next 5 years in the cancer care and survivorship?
Okay, I'm sure the allied health is very equally important because we know, as we said, MDTs are very important. Even in our setup also, the breast care nurses, the colorectal nurses, and all these people are so important. And palliative care is also becoming very important because this patient needs pain control. So all this allied health, it's a teamwork. We always say now it's teamwork. It's not like you go to the one doctor, see the surgeon, and everything is done and finished. That's it. No. Now it's a lot more teamwork, spread out the work, And our breast care support group and support group is also very important. Cancer survivors. So there are a lot of things which are now expanding. So, and all allied health are equally important in our work to take care of patients.
I think it's a call to action for the nurses, at least in the pediatric oncology fraternity. I think many of the pediatric oncology nurses have been very shy, quiet, introvert, leave everything to the pediatric oncologist to deal with. But I think it's about time that our pediatric oncology nurses, people actually start voicing out, start doing things more actively, participate more actively, get more actively involved in the care of the patient as well as care delivery, and of course research. And that's the only way that we can improve.
Not the TikTok yet.
So yeah, I think what as the panel highlighted, I think a lot of doctors those days, I mean, even probably now we are taking charge of everything, and I think we should decanter out and give that support to the other the nurses, those dietitians to give us feedback. I don't mind if they tell me doctor, this patient needs this patient needs that. We have to work to to help the patient in an overall nature, including psychologists. We shouldn't forget that. I have to admit that again. So we have to have a psychologist on board, and I think we all stand in a overall consensus that it's not just about the doctors. It's not just about the other people involved in overall. Amen.
I think that's bring us to the end of this morning session. Very big thank you to our Dr. Teh, Dato Seri, Dr. Babu, and Dr. Arnil for sharing such valuable insights. And it's clear that cancer is more. I think cancer care is just more than just medicine. It's about collaboration, communications, and compassion across every professions, including psychologists. So let me leave you with this quote. Individually, we are one drop. Together, we are an ocean. So let's keep the conversations going on outside the hall. With that, I officially close this morning session and enjoy your coffee break and the rest of the congress. Thank you.